going on. It's not pretty, but
So yeah, Sunday's the big day for me. Tomorrow's the rehearsal dinner, and then we're going to the airport after this to pick up my the rest of my relatives. It's fun. Oh, yeah, Delta. Delta. It's actually going to be here early. I've been tracking the flight.
Wow,
So
everybody's been delayed coming in.
yeah, no, my cousin that's here with me today. I'd love to introduce her to you. She's here. Yeah, she's sitting in the lobby there. Here on this floor. Yeah, we'll go say hi. And then and then my nephew is coming for the first time. So he's a little nervous about speaking in the elevator.
How old is he, Eleni?
Can I tell you something loud? I've been like, at the hospital, I've been living off of turkey burgers and vegetables and this and that to get into the dress. This last week, Alex, I threw so many yards of mulch, and all of a sudden I can eat anything I want and it's coming right up. Let me come introduce you. Oh, let me introduce you to my cousin. Oh, okay. She's been dying to be there. I work with
I'm gonna give it to him.
Megan, you do the Apex, I'll be right back.
We're good here.
I mean, it's not optimal, but
So Eleni was really here to have this here. So he's going to do a little intro with me. We'll have someone wear the vest. Aside from that, I'm just going to be completely up.
Okay. So just introduce
Eleni, yeah.
Okay. All right.
And then unless Ben wants to be announced a different name than I do, Ben's from Money for the
Okay. And then Allie's son is going to demonstrate the best.
It sounds that way. Hopefully Allie's son fits in the back.
Okay. I mean, that's what I was just told, so
Wonderful.
passing it on.
And then will we have a little breakdown period between the next, like right after the airway clearance portion?
Yeah, there's a 10-minute break.
Oh, perfect. I just wanted back. Sounds good. I'll be there for
Okay.
Check, 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 check. Excellent.
so is it the case that like it's just not enough? Is that what the feedback's still coming from? Because I did go out and get those other.
Oh, did you put them in line?
I believe so.
Good plan. You got your presentation right here.
I think you have to put it into,
Open with.
yes. It shifted. It's supposed to be down.
I don't know how to fix that.
Do you have PowerPoint? See how it's there?
Mm-hmm.
There it is. Oh, yep. There we go.
Okay.
And then you can say enable editing.
I don't think it's gonna let me do that. Okay, so we're gonna do it in Impress, which is the version I have.
Is like, that's a different type of
It's
PowerPoint?
basically the same thing as PowerPoint. It's just like it's a different.
It's like an Apple version?
No, it's through Microsoft, but it's just the free version.
What's it called?
It's Impress, I think it's called. So we're gonna do this and do open with. Open with Impress. Okay, there we go.
It does, so is there a way, see like that introductions, it
Mhm.
became, it,
Yeah.
you can click it over, I'm trying to see if there's anything.
Yeah. Let me see.
It's only 12 slides, we can take a quick peek.
Right, we just are already late getting started for our next thing. So, I'm gonna have to see if I can grab somebody. Absolutely, let's just do that. That would make my life easier.
Is this attachment
It's USB-C. Yep, it'll work with that.
sweet?
Yep.
All right, I will
So
have
I'll
it
just
up.
unplug it from here and you can plug it into yours.
Perfect. I'll
Yep.
have it up and ready to go.
Okay.
Yeah, I'm just hoping this is gonna fit him. We should find out if it's gonna fit him.
You never forget the moment when you plan your 8-year-old daughter's funeral. What songs you'll play, what dress she'll wear. how you'll live with yourself if she doesn't make it through surgery. I held my 8-year-old daughter in my arms, kissing her forehead over and over, enough kisses to carry her through surgery, and if she died, enough to carry me through life without her. My story of finding strength I never knew I had started long before that hospital room. We were a normal family once. Me, a shy medical biller, my husband, 3-year-old Carson covered in dirt. Just a family sharing ordinary dreams, until we weren't. When Hallie was born, something was wrong. Emergency surgery, they said. 7 heart defects. Less than 24 hours later, the baby I dreamed of painting toenails with became a medical case with no guarantees. Despair changes a home. The sound of medical alarms shrieking through the night became our new lullaby. Despair doesn't just affect the sick child. My toddler son felt the weight of our family's crisis. The fear and confusion in his little eyes broke my heart all over again. So I'd wrap him in my arms and cry with him, because that's all I had left to give. For years, I was doing the right thing, following doctor's orders, mixing IV nutrition with surgical precision. But the weight of it all was crushing me. Then came the statistics. Only 1 in 3 children make it to their first birthday. Half of those remaining won't see 15. Sitting in waiting rooms full of worried parents, I started accepting the terrible reality that the only way for her suffering to end might be losing her completely. Medical bills piling up, marriage falling apart. Before I knew it, I was out of hope and out of options. Strength's a funny thing when you're a mother. You'd rather break in silence than admit you can't hold everything together. When Hallie was 6, a technician asked a simple question. Have you ever heard of heterotaxy? That question transformed something inside of me. The feeling of being alone melted away. I was standing in the Target's toy aisle when my phone buzzed with a Facebook message. My son has heterotaxy too. Then I called this woman I'd never met right there in the middle of Target. I know exactly what you're going through, she said. She understood that feeling of isolation, the terror of the unknown. Her son's journey was different. Alex needed a few big surgeries. But that feeling like you're drowning alone, she'd been there too. And for the first time in years, I didn't feel invisible. At Heterotaxy Connection, we don't just offer hope, we become your lifeline. When families get diagnosed now, they're connected to support within 24 hours. We pair them with mentor families, show them they matter. We help them become medically empowered, centers of excellences for coordinated care, direct connections to specialists, support groups for siblings and marriages. Family goes from driving to many different hospitals to coordinated care in one location. Each success ripples outward, touching countless other lives. When you support Heterotaxy Connection, you're transforming entire medical systems. Your investment creates coordinated care, so your child gets treatment in weeks, not months. 24-hour family support networks, mental health counseling for trauma, life-saving research initiatives. Right now, a parent sits in their car outside the children's hospital, unable to go inside, unable to face another day of watching their baby struggle to breathe. They've been in this storm for 6 months, no one to guide them, no one who understands. Their marriage is cracking, their other children are terrified, they're drowning. Here's what happens when these families don't receive help. Treatments get delayed, marriages fall apart, families become broken. They feel so small and unable to do anything, like being in a life raft in a perfect storm, not knowing if they're going to make it. But here's what they don't know yet. You survived a storm too. Maybe not heterotaxy, but something that broke you, something that taught you the power of having someone who truly understands. When you join Together We Thrive monthly, you become their shelter. You become the voice that says, I've been where you are. You're going to make it. You're not alone. Because resilience isn't surviving the storm, but it's building shelters for those still in it. Your $67 monthly donation transform you from someone who survived into someone who saves. Click below to become a shelter and be part of Together We Thrive and discover the profound satisfaction of turning your pain into someone else's hope.
All right, welcome back, everyone. We're going to start with a presentation by Nisha Sabin about the Natural History Registry through Citizen Health. Nisha is a dedicated patient advocate and co-founder of Heterotaxy Connection, where she works to educate families, build supportive communities, and advance resources for those affected by heterotaxy. She also serves in the executive leadership of HRC3, helping to unite clinicians, researchers, and families to accelerate progress in research and care. Nisha's work bridges the lived patient experience with scientific collaboration, ensuring the voices of families remain central in shaping best practices and future innovations. Okay, Nisha.
So as part of our CZI Rares 1 grant, we've been given an incredible opportunity to join a natural history study. And so we wanted to take this time at the conference to talk about it and the benefits of it and how it can help our community. All right, so Citizen Health is a company founded by rare disease patients for rare disease patients. They are putting together these natural history studies which allow us to better understand our communities, better understand the challenges that they face, and help us to manage our own care as well. So as we are working towards different treatments and different options for our families, we come across major roadblocks. A lot of patients drop out. Not all cases are supported, and it's a long, expensive process, which means that it's a high patient burden on our patient community, right? So Citizen Health is aiming to eliminate some of that burden so that it is not quite as cumbersome. They empower patients, advocates, researchers, and drug developers with real-world insights from patient-consented data. Natural history stories are the cornerstone of rare disease research. It helps to observe and understand how the disease develops and progresses naturally, establishes baselines, essential for researchers and medical or measuring treatment impacts, and design better and faster clinical trials. Lack of knowledge of natural history limits the ability to understand the conditions and patient unmet needs. So how does it work? So essentially what we do is we give this to our patients for free. There's no cost to our families to be involved. You control all of your data. You control who sees it, who has access to it. You go in, set up your account, and they will go about collecting your medical records. My 19-year-old daughter is our beta tester of this, and I have to say it has been a very easy process for us, and it's already been very, very instrumental in her care. So you go in, you're going to put in all of your locations that you have been seen. For us, she's been seen across the United States. And so they have collected, last time I checked, we were at over 5,000 medical records. And they have collected all of those for her. She controls who sees that. She controls, does she share it with doctors? Does she share it with HC? Does she potentially want to share it to researchers that might be interested? That was very, very important to me, is that our patients control their data. They get to own it. They get to decide who has access to it. This is not something that anybody should make those decisions except for the patient and their families. So a lot of different rare disease communities work with them. Chan Zuckerberg, they have done a lot of research into making sure that this is a trustworthy company. So pretty easy, you create your username, password, give them your basic demographic, and then you sign your consents. Enter in your providers, and they will validate your identity. So no cost. All your medical records are in one location, which is phenomenal. Easy to share. Went to a doctor's appointment with her. Her doctor was like, I'm having trouble getting these medical records. I said, oh, I can get those for you. Logged onto her account, and we had them within minutes over to her provider. You easily can contribute to research without ever leaving your home. And then my personal favorite part is there is an AI advocate. So imagine this. I send my nicely adult child to her first appointment by herself. And she comes back to me and she's like, Mom, have I ever taken beta blockers? And I'm like, yes, that was a bad idea. Don't do that again. Well, why? I'm like, oh goodness, how many years ago was that? I've got to remember that. I've got to go back and research it. And she had answered these questions to her doctor, and she just winged it. She's really good at winging it. And I am sitting there thinking, oh my goodness, we are in trouble. So along comes Citizen Health. Now I send her to her doctor. Her doctor says, have you tried high-level antihistamines? Yeah, I'm pretty sure I did that. When? I don't know. So I jump on. We get on the AI advocate, and I said, when did she try high levels of antihistamines? And it went through, and it's 5,000 pages, so it did take a moment to scroll through all of those and find it. But I had an answer in under a minute. I had dates that she had started it, the doses, why she was prescribed it, and why she stopped it within under a minute. Doctor furthermore goes on and says, oh, I'm having a hard time finding, there's so many medical records. It's hard to scroll through all of these. I need to understand what happened when they tried this medicine for her. And I can't even find where it was administered, let alone how she reacted to it. So once again, log in to our handy dandy little AI tool, and it pulls that up. And it tells them exactly when she took it, what her reactions were, the measurements they took, everything that was documented about that. We're struggling to get the insurance to approve a medication. In the AI tool, it says, help prepare for an insurance appeal. Click on it, and I got a 7-page document of everything related to that condition and what might help the insurance. One of them, they wanted to know how many times the cost of what not treating her would have been. So they're like, how many times has she been admitted for abdominal pain? I'm like, oh goodness. I can't even count that high. Like, I can't even remember how many times. Jump on there, type in, how many times has she been admitted for this? 39 times. So it is a very, very powerful tool to be able to have that at your fingertips. And it's something I am so excited to be able to give to our community to allow them to have access to it. So as you can see, this is our AI advocate. There are so many different things that you can ask it. And the nice thing is this is not like ChatGPT where you're worried about the sources of where it's coming from. It is specifically pulling it from your medical records. They are very security conscious, so follows HIPAA compliance. They are above and beyond anything that I have found in order to protect our information. Our information, I am finding out, is quite valuable, actually. And there are people that really want access to it. And I want to make sure that that is secure and that we are only sharing it with who you are comfortable sharing it with. So this is where we get to start realizing the value of our information. So when we have a big enough cohort, and that could be 20 people in there, it could be 100, I can have companies, researchers come to us and say, we want to pay you to access this information. And that money comes to us directly. It does not go to Citizen Health. It comes directly to us. There again, you choose whether you share that information with them or not. You'll get a notification. You get to choose whether you are okay sharing that or not. They're working on getting this in different languages. Obviously, we have patients all over the world. And sometimes gathering medical records from across the globe is challenging. So they are bringing on translations about as fast as they possibly can. Right now, they are currently not collecting outside of the U.S. the medical records, but what they do recommend is that you get the medical records and you can upload them yourself. And then their AI assistant will pull that all together. One of the things I really like is that sometimes, as we all know, you read a medical record and you're like, they told me that they were diagnosing them with this, but it's not in the medical record. Or, maybe it says the patient has low muscle tone. Well, AI is going to link that to dystonia, and all of a sudden, we can start to find commonalities among our community. Little things that previously get overlooked because doctors word it different. Medical records don't always reflect exactly what the doctor told you. So, a lot of options for us. So in less than 3 years, Citizen has enabled immense research acceleration for rare diseases. There's a big, big focus on this. So they have gotten over 11 manuscripts printed, 25 abstracts, 15 biopharma partnerships, and it continues to grow and develop with here. And with the influx of CCI funding, it will continue to explode. With Citizen, Praxis obtained IND clearance from the FDA 4 years early. When you have access to some of this information, it saves countless hours upon hours upon hours upon hours of research. Imagine what one little research assistant would have to do that now our AI assistant can do in just under, in minutes. So it's accelerating treatment drastically. So our goal in the next, by the end of the year, is to get 50 signups. This is something I'm passionate about. I've seen it in our lives. I've seen how it benefits us. I've seen my daughter walk into appointments far more confident in her ability to manage her own care. She no longer has to be like, I don't know that answer. She's like, wait a second, let me look that up for you. She comes across as a lot more prepared. We're not turning to ChatGPT for some of these answers. We're turning to our own medical records and to the assistant to help us with this. So, obviously, there's a lot of benefits to this, benefits to research, but the goal is to support our communities in the end. So, as we find better treatments, as we find better options for our families, we need the research, and we need it to benefit our communities. I don't want to just give this to big pharma or anything like that just for the sake of doing it, but because it truly benefits our community. And so it helps our newly diagnosed. It helps along the patient journey, helps with medical management and treatment plans. So as you can see, this will walk you through a little bit more just what it's looking for and what it will attach it to. It will attach it to ICD-10 codes, even if it is not specifically saying that that person has that. And then the nice thing is you can share this with your providers. Now, do be aware that sometimes providers, institutions do not allow them to access that, but you are able to share directly with providers. You just put their email in, and away they go. They have access to everything that you give them access to. So clinician and community support, we're hoping to explore better treatment patterns across cohorts to understand, are there opportunities to drive better standardization? Are certain ASMs or combination of ASMs used more commonly? How many ASMs do patients try? What is the use of polypharmacy in the population? So as we get more and more people involved in this, we can overlay key data to compare and to illustrate patterns in key outcomes over time. We can explore relationships between phenotypes, as well as associations between interventions and outcomes. The more robust we can get this registry to be, the more power we have behind the force that we put towards research. We can control and help to influence where research is done based off of the data that we share. So we will have pamphlets about this. We have them that will be at our resource afternoon, or this afternoon. So we'll have pamphlets that will have QR codes. Maria here has been our expert. She's done all the training, so she is going to have a computer that she can sit down and help you sign up if you would like. But Maria is our go-to for this. So does anybody have any questions? Yeah. Mike. I know, Monica asked so many questions.
Hello. Okay. I know this information, with all the HIPAA and security, and we can give access to this information. I'm curious, I don't know if you know this, if, because heterotaxy, some of us have other diagnoses that we don't know are related to our overarching condition or not, and would this resource help us to weed that out?
Absolutely. So my daughter was actually diagnosed last year with another rare disease that is 5 times more rare than heterotaxy. So it's been a challenge to kind of parse out what is heterotaxy, what is this other condition. And I can type into this, AI assistant. I need everything about HAE. I need anything that pertains to her heterotaxy. Are there things that might overlap between the two? And it gives me that information. So this is not just going to focus on a heterotaxy. I know a lot of our kids have multiple conditions, and it will help you figure out what is what and help you find that documentation to support that. All right. Well, thank you guys. Once again, Maria will be at our resource fair and will answer any of your questions or any more questions or help you get signed up if that's what you are interested in.
All right, thank you, Nisha. We'll now have a airway clearance workshop, and this will be led by Eleni Moulis. And she's a cardiopulmonary specialist in the pulmonary clinic at Boston Children's Hospital.
Hello, everyone. Good afternoon. It is my pleasure to be here with you this afternoon to discuss the importance of airway clearance and different types of airway clearance. I am very fortunate this afternoon to have with me Jennifer Rifrigieri from Moynihan Healthcare and Megan Marshall from Baxter Corporation. Why we're having this airway clearance workshop? It is very important as cold and flu season and pneumonia season begins. And the best evidence shows that daily airway clearance helps the pulmonary system, and it also keeps our children healthy. At Boston Children's Hospital, we take great pride, and we are vested in taking care of your children. When your children walk through our doors, they become our children. And with that said, I would like to show you some different types of airway clearance. We will have some hands-on and show you how the devices work. Some are, electric, some are portable. There are many different types, and that's what we'll be exploring in the next half hour. And with that said, Jennifer.
Okay.
Great. So thank you, Eleni. Why do we use airway clearance devices? Well, with heterotaxy, there's a plethora of different surgeries out there, and there's concern of post-op pulmonary complications, on top of perhaps just having issue to begin with bringing up secretions. This is a way to help keep those lungs healthy and mimic that of the cilia within the lung so that they are able to bring up those secretions that make you feel, how shall I say, verklempt. So it is a technique that helps people clear their mucus from their lungs. There's various methods out there, like Eleni said, but today we're going to be focusing on just a few to give you guys a breadth of what we have. So more importantly, today we will be discussing what is called the Aerobica device, and there's one here. And with this device, again, it is helping to replicate that of the cilia to bring secretions up. As you can see, this is very portable, discreet. It is something that you can either keep in your backpack, keep at home. For patients that are looking just to have a regiment of airway clearance, twice a day is all that is needed. So this being kept in the medicine cabinet at home is sufficient so that when they go to brush their teeth in the morning, brush your teeth in the evening, this is a proper way to help keep that regiment going and keep those lungs clear. Now, other scenarios where they might start to build up secretions, we recommend using it up to 4 times a day. And so it's a way to be able to have a device that helps to bring those secretions up. There are actually 5 different resistance settings within the device. I'll go through the mechanics in just a minute. But this basically gives more back pressure as the patient is exhaling through the device, and in turn helps to stent open the airways. And then there's a vibratory component that helps to shake up the lungs and provide those secretions coming up. Similar to that of chest PT, I like to joke that this is kind of like chest physical therapy in a bottle or in a little pocket device. One of the other things is that this is good for an entire year. So something that is very important to keep in mind is that because you're breathing in and out of these devices, we want to make sure that we're cleaning them as well. And we'll go over the cleaning instructions in just a bit. There's no side effects. This is a drug-free way to get those secretions up and out. It's kind of like jazzercise or aerobics for the lungs. It's a way to just help exercise those lungs, get the secretions up and out, and as said, it's good for 12 months. Now, for those of you who are engineers and really want to understand the dynamics of certain things, with the device, when you inhale in, if you see the one on the furthest to the left, that is as the patient breathes in, there's a little green flap here that moves forward. And then when the patient goes to start the exhalation process, that flap moves back up, and then the exhalation carries down through here. And right at this point is where the patient receives their resistance. Okay, so it's just a little area of, or surface area that the patient is exhaling through to receive their resistance. And again, you are able to make that resistance more or less, so the opening becomes bigger or smaller as you are adjusting that resistance. And then it carries up and through to this vein that shakes back and forth, that again, kind of provides that vibration, having those secretions start to come up through the airways. As far as proper technique, we are gonna watch a really quick video on doing this. But in general, you always want the patient to be sitting upright. You wanna make sure that they have a long, exaggerated exhalation as they're exhaling through the device, and have it 3 to 4 times longer than that of the inhalation. And we'll see that in the video in just a sec. And one of the things that I get a lot of questions about is how do we know the resistance settings? And again, a lot of times what I'm working with is in the hospitals and dealing with the respiratory therapists and the nursing out there to help explain how we have our resistance settings. But the goal for our patients, the goal for the children out there, are that we want them to have, be able to achieve 10 consecutive breaths through this device. That is ideal scenario. If they can't, we're gonna reduce the resistance setting down to be able to open up that surface area bigger and make it easier for them to exhale through. And so those are one of the key things, is really making sure that they do this not for more than, our product insert says not for more than 15 minutes. God love you if you keep going beyond that. But to not, just to be able to do 10 breaths, pause, have what's called a huff cough. We'll go over that in just a sec. Bring up those secretions and then repeat. Okay, so I'm gonna play this little video. Oh, no. Apologize. I wanted to make sure it was playing beforehand. Okay, conference. Oh boy. Oh, now it's. V as in Victor. Oh, B as in Boston. OS. Yep. DM. Right out Marriott. 2. Okay, thank you, apologize for that.
Please follow these simple instructions when using the Aerobica OPEP device. Check that your resistance indicator is set as prescribed by your healthcare professional. Put the mouthpiece in your mouth, closing your lips around it, forming a good seal. Make sure your hand does not block the open circle at the far side of the device, opposite the mouthpiece. With your lips still sealed around the mouthpiece, inhale deeply. Hold your breath for 2 to 3 seconds before exhaling actively, but not forcefully through the device. Active exhalation should last 3 to 4 times longer than inhalation. Keep your cheeks flat and firm. For example, you should exhale with a firm, steady breath, similar to blowing up a balloon, rather than using a fast, forced breath, which is similar to blowing out candles. Continue taking deep breaths and long exhalations for 10 to 20 breaths, or as instructed by your healthcare professional. After which you will perform 2 to 3 huff coughs to clear your airways. To huff cough, sit up straight with chin tilted slightly and mouth open. Take a slow, deep breath to fill lungs about 3/4 full. Hold breath for 2 to 3 seconds. Exhale forcefully but slowly in a continuous exhalation to move mucus from the smaller to the larger airways where it can be coughed out. Continue with the Aerobica device and huff cough cycle for 10 to 20 minutes, or again as prescribed by your healthcare professional. Treatment should be performed twice each day and increased to 3 to 4 times per day if you are producing a lot of mucus. Stop using the Aerobica device and contact your healthcare provider if you feel dizzy or lightheaded or if you have any discomfort.
Okay. Great, so we're gonna quickly go over how to properly do this. I have Vanna White, AKA Elaney, down here to kind of help and demonstrate. Let me detangle myself. So again, with this device, it comes either with just the mouthpiece, or you can have one with a manometer that allows you to have a visual of how you're doing upon the exhalation with the device. It'll always come in the number 3 setting as resistance. So again, you're gonna go up or down depending on if you're able to accomplish those 10 breaths, and also, are you able to bring up much secretions? So, per the video that we just watched, I'm gonna ask Elaney here to be a very nice patient, maybe, and be able to do this device. Again, Elaney, when we put this in our mouth, we wanna be able to take a nice breath in, do a little small pause. No, not in through your nose. That's a great question, because actually what we would need to do is maybe plug or provide nose clips, because the effort and the benefit that you're going to be receiving is upon the inhalation through the mouth, not breathing through the nose.
So the other thing I see a lot of in the pediatric population is, unfortunately due to devices, I see a lot of rounded shoulders, which shortens the pectoralis minor muscle. And so a big thing that I encourage with these children is to open up the rib cage where you can take a deeper breath. That's great posture. Feet on floor. Sit back in the chair. It's very important. And this is what you do. So I take a deep breath in. 1, 2, 3.
Long exaggerated breath out. And you want to, in this case, we can see with the manometer, the device starting to show the exhalation. And rather than having that exhalation manometer be going up and down, kind of like a wave, we want to see it stay consistent. So as you're exhaling, 1, 2, 3, perhaps 4, then stop.
So then from what this mimics basically is how the cilia beats in the lung. It beats between 14 and 16 hertz. And when you're getting that fluttering, that's what it is trying to mimic, and it will help with the mucociliary transport. It's like a mucociliary elevator, and brings the secretions up so the patients can expectorate them out. That's what the idea behind this device is.
And so yes, after she does, say, those 10 breaths, okay, 10 proper breaths, and produces that desired exhalation, we would then ask her to stop and do what we call a huff cough, okay? And when we do this huff cough, we always want to have a tissue in hand, not a cloth napkin, but a tissue in hand.
Or a little mirror for the little one, because the little girls love fogging the mirror. That's
Yes.
another thing you can teach them.
And being able to, after those 10, go and hopefully have some secretions to bring up. You have the tissue, perhaps a cup, to be able to catch those, take a quick break, and then start again.
I start another cycle. What I recommend is this done either with if your child's on nebulized therapies, albuterol, and any type of nebulized hypertonic saline, is actually, the Aerobica is a wonderful device because, and why we like it as clinicians, you can put your nebulizer on the back of it. So as your child is taking the breaths, they're also doing their nebulized therapies. It's a wonderful device. The other thing, why do we at Boston Children's, we tend to, advocate towards the Aerobica? The material it's made out of can go in a baby bottle sterilizer. You have to be careful with dishwashers because of the dishwasher filter sometimes has bacteria that, some people don't open up their filters enough, so I really kind of stay away from the dishwasher. But you can wipe it down with rubbing alcohol, and you can, after each use, you rinse it with some soapy water, and we recommend Dawn, dishwashing and air dry it, and it comes apart very, very easily.
Yes. And so that brings us.
Yeah, they both work.
Here we go.
You get it?
Nope, I don't. Oh. There we go. Pass back. So that brings us to the next portion, which is going over the cleaning instructions that she was just alluding to. So again, this device comes apart really into 4 different pieces. You just pinch the middle here. You are able to have the bottom cartridge, the middle here, where I showed you, you get your resistance and also the oscillation here. And then the top portion plus the mouthpiece. If it has the manometer, you don't want to wash the manometer. That remains outside of the dishwasher and outside of the sterilizing process. But with these devices, as said, warm soapy solution, rinse clean, let air dry. That's always a beautiful method. Dishwasher, as Eleni said, you may or may not, depending on if this is something that you might not be regularly cleaning those filters, perhaps like myself. Or you have 5 methods of disinfecting, and these are all within the CF recommendations as well. So just keep that in mind. And one other thing is, compared to the other type of pocket OPEP devices on the market, this is good for an entire year. And one of the things that allowed us to get that FDA approval for having the year time frame is that once a month, we do recommend having a 1 part warm water, 1 part vinegar soak, because depending on where you have your water, what type of, if it's soft water, hard water, there is mineral buildup that does start to occur with these devices, so we do recommend having that ability to have the soak as well. So we talked about some of those breathing techniques, and also recommend kind of that belly breathing, because again, nobody feels good when you can't quite breathe or take that big breath in or be able to exhale out if you feel like something's always stuck there. I am going to be turning it over now and to Eleni, and then she'll introduce Baxter.
Thank you, Jennifer. That was very informative. Great presentation. And now I'd like to extend a warm welcome to Megan Marshall from Baxter Healthcare. And we're going to be looking at another device that we use a lot and we prescribe a lot in our pulmonary clinic, and it is the pulmonary percussive vest, which is also known as high-frequency chest wall oscillation. So it's a little different. It does involve a device, but we're here to show it to you.
We do have a wonderful volunteer. Ethan's going to come up.
And we'll get a chair for him. Yes. So, again, just like the aerobica, the chest, we call it the vest. The vest works by, it basically inflates, and the inflation, it's air, and the air puts some pressure on the chest wall, and it shakes. So again, we're mimicking the cilia beating in the lung and the mucociliary elevator that brings secretions up from the lungs where you can expectorate them out. And this treatment is done, again, after nebulized therapies or inhalers. You usually wait about like 10, 15 minutes and to give an optimal treatment. And when we first prescribe them, we prescribe 20-minute therapies, and then as the children get older, we go to 30 minutes, and we use some different frequencies, which Megan will show us in a minute. Thank you. Volunteer. And again, Ethan has very nice posture, and he's got his feet on the floor and his shoulders back. You're a great patient.
So typically, these are our newer garments, so typically we actually want it right under the chest. It is a little bit big for Ethan, but we're making the best out of it. And we do start in different frequencies and pressures. However, right now we're on lower settings, so we don't make him sick after he just ate his lunch. The way it does work, though, so the high frequency chest wall oscillation, we're really looking to get the secretions from the lower airways up to the larger airways, and then we can expectorate them out, like similar to the aerobica, just in oscillating form.
And then the other thing you have to keep in mind and the other thing you have to keep in mind that younger children are not going to expectorate. Young children usually swallow their secretions, and that's okay as long as they're, they're still coming out, but they're going in their stomach. And sometimes when there's too many secretions, they may get a little, they may cough up, or the secretions will, like a whole bolus of, like, you think they're throwing up, but it's just secretions. That happens. And as children get older, and with the huff-cough technique, you can expectorate those secretions. And that's what's going to keep the kids healthy. All right, ready, Ethan? All right. So this is the APX system. This is brand new. This was just released within 2025. And we've gotten great results with it. Can you say hi for me? Hello.
Does he get nauseous?
Did you ever get sick? No? Okay. He's great. Good.
So just to show the difference from what 10 to 16 hertz.
Right. So this is going to shake more. So the idea is you start off at a lower frequency to get the smaller airways. Then you go to a medium, and then you go to a high frequency so you can get the secretions out. Are you having fun? Sure. Yeah, want to say? Oh, okay. Well, Ethan, you've been a great sport. Thank you, Ethan. Yes. So, oh, yes. Yeah, so we did the other device. And the other thing is good old-fashioned, chest PT, percussion, vibration. We actually start when the kids are babies. We will do formal teaches. We'll teach the parents, whether in the hospital or in an outpatient setting. We will teach the manual techniques of chest PT. And then when they're about, I'd say, then this is our facility, our clinic. When the patients are about, when the children are about, I'd say school age, that's when we introduce a vest and or the aerobica, the PEP device. And then the PEP device, one great thing, Jennifer, is that you can travel with it. The Apex, this new Baxter device is, you can go through TSA with it. Usually your pulmonologist will give you a letter to fly with it. And it fits in, you can take it in as a carry-on. But you can also put it in the hull of the plane as well. But the aerobica, I give a lot to my athletes who will go, athletes or anyone basically who will go fly, and it's easy because you can put it right in your bag. But I stress the disinfection because you don't know what the children can have. And the last thing I want to talk about before we wrap for today is the importance of exercise. Every child has something that they love to do. And to keep the children active, that's a form of airway clearance too. We at Boston Children's, we are great proponents and we encourage exercise. I think it's a wonderful thing, and playing with peers is a part of growing up and a part of natural development. So with that said, does anyone have any questions like that they'd like to ask? Yeah, yes. Oh.
So one thing a lot of times our kids are recovering from surgery, abdominal surgery, chest surgery. So what are some things that they can do while they aren't able to do maybe the chest percussion vest or whatnot in order to help keep those lungs open and healthy?
Incentive spirometry. In my time in the ICU before, I've worked both services, inpatient and outpatient, and I worked in the ICU. The big thing is, one of the greatest thing is that evidence show, Nessia, that when children are mobilized earlier, when you get them up and out of bed, you decrease a hospital stay by 3 days. That's what research is showing us. And then I teach a lot of diaphragmatic breathing, and I do a lot through play. A lot through play. Like I'll say, okay, let's get you up, let's get you moving, and we'll do something fun like a scavenger hunt. And and then the other good thing is you can do a lot of splinting of the incision and taking breaths. But and the minute you start with the mobilization, early mobilization is a program that was started in Hopkins, BCH, all of the bigger pediatric facilities, and it's now an initiative across the United States. So that's one of the big things to do. Yeah. And the other thing we used to do a lot was blowing bubbles too, is a big thing. Yeah. Thank you. Good question. Anyone else? All right. Well, with that said, thank you very much. It was our pleasure, and we look forward. Anyone would like to have any questions, feel free to email us. Our contact, we can provide you with our contact information, and we're always available and happy. And it's with great pride we take care of your children. Thank you.
All right, thank you, ladies. That was a great workshop. For the next 20 minutes, we're going to have a break. You can stretch your legs, get a drink. We'll see you back.
Oh, go pee real fast and then come back here. We're gonna do a border.
What is this called?
So our option is to remain with one screen, or I have smaller screens, so I can put up a second screen. It's not going to be the same size, but it's on the other side, just so we can accommodate this to that's going to be the same process again.
I would say, as long as you guys are okay with it, I'm good.
There are a couple of people that really want their video clips to work out. One or two people may want to pivot over. Okay. Yeah, no, they actually, I meant to get to you earlier, so that they were ready for you before I even went down there. So you're already checked into a room. They just have to actually.
You can take them in.
Yeah. Okay. Awesome. I'm still here, but I'll definitely see you guys in the window. Oh, yeah.
Yeah, no problem. Okay. All right, we're going to go ahead and get started again. Our next presentation will be on fever protocols, immunizations, and antibiotic prophylaxis by Dr. Douglas McDonald. And Dr. McDonald is a senior associate physician in pediatrics at Boston Children's Hospital in the Division of Allergy and Immunology. He graduated from Case Western Reserve Medical School with a PhD in neurosciences and MD. His pediatric residency was completed at Cincinnati Children's Hospital. Dr. McDonald completed fellowship training in allergy and immunology at Boston Children's Hospital, studying primary immune deficiencies involving defects in NF-κB. He currently treats patients with a wide variety of allergic and immunologic disorders. Dr. McDonald.
He's giving people handouts.
So, I know you've heard a lot of really amazing things about the heart. All right, there we go. All right. So I know you've heard a lot of amazing, really complicated things about the heart, genetics, and the lungs. But as an immunologist, I think we need to turn our attention to the spleen. I don't think the spleen gets enough love and attention, so I'm here to correct that. So, the issue in heterotaxy is there can be asplenia, polysplenia, so basically anywhere from absence of spleen function to impaired spleen function. And what that results in, unfortunately, is susceptibility to some overwhelming infections. So I think it's helpful just to give a little bit of background on the spleen. I'll be going into more depth tomorrow. But the spleen you can think of as, if like for a car analogy, the oil filter of the body, basically. So the spleen is an organ commonly located in the left upper quadrant here underneath the rib cage. And it receives blood directly from the circulatory system. And what it does is it filters the blood continually. So roughly speaking, the spleen is divided up into two distinct sections, one called the red pulp and one called the white pulp. So the red pulp is basically these sinusoids where the blood is filtered through a series of macrophages, and these are really tight little sinusoids, and the way it works is blood cells, particularly red blood cells, as they age, there can be hemoglobin proteins that precipitate in the blood cells, and they form what's called little pits. Also, there can be remnants that accumulate in red blood cells during development called Howell-Jolly bodies, which are nuclear remnants. So in a normal functioning spleen, what happens is the red blood cells squeeze through these little channels in the red pulp, and those pits and the Howell-Jolly bodies aren't very deformable. So what happens is they basically get shaved out of the red blood cell, okay? And then the membrane kind of reanneals, and then the blood cell goes on its way out in the circulation. Older blood cells will present a molecule on their surface called phosphatidylserine, and that signals to the macrophages that these blood cells need to be removed from the circulation, and all of those products get recycled. The white pulp, on the other hand, is a site where a lot of complex immunologic reactions happen. So the spleen not only filters old blood cells and cleans them up, it also is a place where pathogens like bacteria and viruses get filtered through. And as they go through the macrophages in the red pulp, they may recognize and engulf some of those bacteria. As the blood and all of those pathogens are presented to the white pulp, there are a variety of cells in the white pulp that then recognize those foreign bacteria and viruses and elicit immune responses that go on to protect the body and help ultimately clear infections of all sorts. There are a specialized set of lymphocytes called B cells, which produce antibodies. And a subset are quite unique to the spleen. They're called IgM memory B cells. They sit in an area called the marginal zone, and you can think of them as one of the first lines of defense against certain bacteria, in particular strep pneumococcus, Neisseria meningitidis, and Haemophilus influenza type B. These are difficult bacteria because they have these slippery capsules which are comprised of polysaccharides, and they make it difficult for the macrophages to engulf them, and they're resistant to being coated with special proteins of the immune system called complement. So what these memory B cells in the marginal zone, which are kind of particular to the spleen, they secrete these IgM antibodies right away, which can bind to the polysaccharide coatings on these bacteria, and that gives the immune system the ability to help clear those particular subsets of infections. So in a situation where we don't have a spleen, we don't have that filter, and we don't have that immediate immune response from the IgM B cells, so that gives bacteria like Streptococcus pneumonia and Neisseria meningitidis, encapsulated organisms get a better chance to grow and overwhelm the body. So that's why absence of a spleen or impaired splenic function is so dangerous. So what do we do? Well, as immunologists, what we counsel our patients on is that if they develop a fever, and we're concerned about fevers that are greater than 101.3 degrees Fahrenheit. If they develop a fever, they need to be evaluated by a physician, primarily in the emergency room, so that you can get blood cultures and get a dose of antibiotics while the cultures are pending, so that they can be protected against these infections. Although the overwhelming infections are fairly rare, when they do occur, there's a 70% mortality rate. So it's really important to prevent this type of a situation from occurring. So the way we do it is we tell patients basically for fevers greater than 101 degrees Fahrenheit, we need you to go to your nearest emergency room, check in, get looked over. They can do viral respiratory panels, and they can do the blood cultures. They can give a dose of antibiotics while the cultures are pending, okay? So why this temperature of 101.3 degrees? Well, the studies have shown that the incidence of overwhelming infection is much lower below 101 degrees Fahrenheit. So we use that as our cutoff for patients to seek attention. But for kids who have just kind of low-grade viral symptoms, cough, runny nose, fevers less than 101, they can be managed at home. And if they don't progress, then that is a wonderful situation. So that is our fever protocol in asplenia and hyposplenia, and that's kind of the logic behind why we do what we do. So I'll stop at this point. Does anybody have any questions or concerns regarding any of this information? Yeah.
So this was actually asked on one of our support groups. When we're talking about a fever cutoff of 100.3, that's before we give medication, right? So
101 degrees Fahrenheit. 101 degrees Fahrenheit is our cutoff. Anything above that, we would really prefer that they get evaluated by a physician.
But the question is, the temperature needs to be before they give them ibuprofen or Tylenol, correct?
That's correct.
Right? Not wait until you've given it that and wait for it to go down.
Right.
And then have a sustained fever, but just if you hit that threshold before you take the medication.
That is correct, yes, yes. And that's a great point. Any other questions?
Some of our families have been given 100.4 as a fever threshold. Has that changed recently? Like you just mentioned that study. Can you just speak to kind of where that shift has come and maybe what the most recent guidance for the 101 is?
Yeah, so that's what's based in the asplenia literature, the 101.3 degree cutoff, and kind of based on the incidence of bacteremia above and below that cutoff. I certainly don't have any arguments against setting that threshold a bit lower. It's just that basically what we're trying to do is set a threshold whereby you're not going to the emergency room all the time, okay? So if we stick to that 101 degree Fahrenheit, I think that will give kids, you know, the opportunity to get a routine cold, low-grade fever without going to the emergency room too often. So there is kind of advantages and disadvantages to the different cutoffs. Yes.
I feel like I ask all the questions, sorry. So in our community support group, discussions over this fever protocol are probably the most common. So here's what, the longevity of the fever. Is that different in complex kids like ours than from normal kids? Because, for example, my daughter's physician says if she has a fever that's exceeding 5 days, doesn't matter if there's no other symptoms, if that fever is not going away after 5 days, come in. Should that threshold be the same for a child that's complex CHD, and asplenia?
Mm-hmm. Yeah, and I think that's an excellent question. So what I would say is for fevers that are going on, smoldering longer than expected, it is worthwhile getting evaluated by a physician. They could check a respiratory viral panel to see if there's evidence of viruses. And it's just good for those kids to have eyes laid upon them, just to make sure that there aren't any other localizing signs that might need to be addressed. Does that help?
But is the length, the rest of the length?
Yes, I would say yes. Even in the setting of ongoing low-grade fevers, if it's persisting beyond your usual cold duration, I would get that child evaluated. All right. So how do we prevent infections? Well, there's really, from an immunology perspective, there's two cornerstones. One is antibiotic prophylaxis. So this really applies to that subset of patients with heterotaxy, with asplenia or hyposplenia, meaning reduced splenic function. So there are plenty of patients who we evaluate. We evaluate their splenic function, and just to kind of backtrack, the way we do that, at least at our institution, is by sending off an RBC pit count. And that assay is done in a specialized lab at Cincinnati Children's Hospital. So the cutoff is 1.3% pitted cells in the circulation. If that number is greater than that, then we interpret them as being hyposplenic. And typically values greater than 14 to 15% are what we will find in patients with asplenia, okay? So that's kind of the cutoff. The other assay that we do is we quantitate those special B cells that I talked about, the IgM positive memory B cells. If those are also low, that's also another marker that supports hyposplenism, okay? So for those patients, we typically recommend antibiotic prophylaxis. And our most common choice of antibiotics would be amoxicillin, because it's relatively easily available. And we usually give a dose of 10 milligrams per kilogram twice a day. Okay? You can also use penicillin VK as an alternative for patients who are amoxicillin allergic. There are macrolide class antibiotics that can be used, such as erythromycin, azithromycin. You can oftentimes use first-generation cephalosporins like cephalexin as an alternative. I will say, putting my allergist hat on, that amoxicillin allergy generally gets overcalled because there are so many kids who get rashes when they get sick, and they happen to be taking amoxicillin at the same time, and they get labeled as being amoxicillin allergic. So as an allergist, I will say that a presentation for allergy that is very low risk is for a child who has an infection, they're getting their first course of amoxicillin, and like a day or two into the course, they get this non-specific red, non-itchy rash. That is not likely to be an amoxicillin allergy. Typically, amoxicillin allergies develop after a prolonged period of exposure, after 7 or 10 days, and that's usually associated with hives, itchiness, swelling, those types of symptoms. But if you have a child who's been labeled amoxicillin allergic, I'll put in a plug and say, it's good to get them evaluated by an allergist to see if you can clear them of that allergy, because it just opens up a lot easier care by removing that allergy label. Okay? So that is antibiotic prophylaxis choices. And so how long do we recommend? Well, there's no universal recommendation for the duration of antibiotic prophylaxis. Many will stop around, say, 5 years of age. In Britain, they usually go a little bit longer, towards adolescence. The one reason I don't like stopping at 5 years of age is because that's an age where kids are going to kindergarten and school, and they're starting to get exposure to a lot more infections, hence more fevers. So I kind of favor, at least in that stage of life, continuing on. But it's a discussion that you can have with your immunologist, and if your child is doing well, they've been evaluated, they've got normal immunoglobulin levels, they've got protective antibody titers to strep pneumococcus, to meningitis, to Hib, it's not unreasonable to stop antibiotic prophylaxis at that time. You just need to have a discussion about, again, fever protocols. The risk of overwhelming sepsis is a lifelong one, so the same approach needs to be taken with fevers, whether you're on antibiotic prophylaxis or not. So for fevers greater than 101, they still need to be evaluated by a physician and treated presumptively while that culture is in process, okay? Any questions about antibiotic prophylaxis or duration of therapy?
I'll come and ask just another question that's commonly come up in our community is, if your child does get a different infection per se that's, they're being prescribed a different antibiotic for, let's say like Bactrim for a UTI, do they continue taking their prophylaxis at baseline? Is that something that changes or suspends whether or not they take their prophylaxis if they're requiring antibiotic for something else?
Yeah, typically we will have them just take the therapy that they've been prescribed, and they can stop the amoxicillin at that time, and once they have completed their therapy, go back to the antibiotic prophylaxis.
You just reminded me of another question that had come up, is when prophylaxis is being asked for say, like dental work or like something that one really particularly comes out, are they supposed to take the exact same prophylaxis that they're taking, or does that become different when they're having that type of procedure or surgery?
Yeah, great. So, so typically for procedures, we do recommend making changes. So typically we will recommend a higher dose of amoxicillin, typically 50 milligrams per kilogram an hour before the procedure. But if it's a different body site that may have different flora, we may go to something different, perhaps augmentin for broader coverage, or something like ceftriaxone. So it's good to keep procedures in mind as well as what particular site. And you can talk to your immunologist or an infectious disease specialist about what the best treatment would be. But typically that low amoxicillin dose is not going to be sufficient during a procedure. Yes?
Another discussion in our family group is who is managing the prophylaxis, and does that change the decisions made as to dosage and how long to continue? For example, there are a lot of kids who are in areas where they still see heterotaxy as a cardiac issue, and it is a cardiologist that's managing the prophylaxis. Other areas, somebody has 10 million specialists, and they have, a complex care pediatrician helping to manage, and everything's coordinated, and they've got immunology on board. So, and then some people, it's their PCM just making those decisions. And so how do we advocate to make sure we're getting what's right for us, the heterotaxy kiddos, based on their splenic function?
Yeah. So that's a great question, and I don't think that immunologists per se, have the right away on antibiotic prophylaxis. I think there are a lot of physicians who are well versed in antibiotic prophylaxis. So I think as long as they're sticking to the guidelines, which is easily available nowadays, just so long as you've got a knowledgeable physician, it doesn't matter if they're a cardiologist, immunologist, or even a primary care physician, just so long as you've got somebody helping provide guidance. All right, so any other antibiotic questions? This is really helpful because we're covering all the bases, basically.
What would you say, because this is also something that's on our group about, some people are told by their physicians or specialists that they don't need it ever, use other things. And then some are like, yes, they need it 100%. What would you tell families how to advocate, or if they feel really strongly that they need to be on this and then their doctors are saying, no, they don't? If that makes sense, just have that conversation.
So that is an important question, and I think there needs to be good dialogue between your child's physician and you. What we do know is that impaired or absent spleen function infers a lifelong risk of overwhelming infection, okay? Not everybody is going to need to be on lifelong antibiotic prophylaxis, but some might, okay? Because some kids are much more complex than others, and they may have developed significant infectious complications along the way, and that's probably somebody you don't want to take off antibiotic prophylaxis, okay? But if you've got a child who has good antibody levels, good antibody titers, has really been very healthy for many, many years, I think it's reasonable to discontinue antibiotic prophylaxis. You just have to keep in the back of your mind that the risk is still there with those higher grade fevers, or in the setting of a prolonged fever, okay? And certainly, kids who would develop other symptoms of concern like shaking, chills, and things like that, those are kids that we want to get evaluated right away, okay? So I think that covers a lot of the issues regarding antibiotic prophylaxis, and it's hugely important. It really has prevented a lot of infections in asplenic patients, probably by 50 to 80%, so it's a very significant improvement in quality of life for those patients. The other cornerstone to keeping our kids healthy with heterotaxy and splenic impairment is vaccination. So the good news is that the pediatric vaccination schedule covers Haemophilus influenza B, strep pneumococcus, and and tetanus and other things. It doesn't include meningitis, but those pneumococcus and Hib are covered in the standard pediatric immunizations within the first year of life. And the literature has shown that in terms of overwhelming infections, pneumococcus is by far the most common organism, followed by H. flu, type B. So they're getting those immunizations in the first year of life and should be getting really good antibody protection from those immunizations. We can also add meningococcal vaccine in the form of Menveo, which is a meningococcal vaccine that's given to children under 2 years of age, and that's a 4-dose series that can be given along with the other standard pediatric immunizations. Okay, so you can have a discussion with your immunologist or care provider about whether you would like to add the meningococcal series at the same time, or after they've completed the standard, would they like to do it perhaps a little bit later. They're going to stay on the antibiotic prophylaxis, but kids over 2 years of age would then require a 2-dose of a different meningococcal vaccine, which is known as Menquadfi. We used to, there was another one that we used to recommend, Menactra, but I think that's been discontinued. So Menquadfi is the one that we're using at this point. And then up around 10 years of age, there's a meningococcal type B vaccine called Bexsero, which is recommended to give protection against meningitis type B. Okay, so those are the vaccine recommendations. And again, it's been hugely helpful in keeping kids healthy, out of the hospital. As an immunologist, I like to, after they've received their series, check their antibody titers and make sure that they've responded well. Because sometimes we pick up kids who either have low immunoglobulin levels, and that's not always anticipated, or they don't respond as vigorously to the vaccines as we might expect. We need to identify those kids because they're in a bit of a higher risk category. But as an immunologist, what I've seen is there are subsets of kids who don't respond to the vaccines well, particularly earlier in life, but they do, as their immune system matures, they will subsequently respond, and it's good to be keeping an eye on that. But for the kids who are not responding for whatever reason, we need to keep them on the antibiotic prophylaxis. And as we work them up, we find that there are unexpected deficiencies in the immune system, like they don't make adequate immunoglobulin levels, they don't respond to the vaccines at all. Those are kids that we might want to provide extra support in the form of immunoglobulin replacement. So it's good to have an immunologist kind of keeping an eye on these kids, just so we can make sure that they're getting the best protection that they can get. Any other questions?
I'm just full of them today for our community, just because so much of this comes up. For kids who are some of our more complex kids who spend significant amount of time in the hospital, particularly in the first couple of years of life. Maybe they spend the first 6 to 9 months in the hospital, they have multiple cardiac surgeries, they're very frail, and they're walking out of the hospital, and routine immunizations have just kind of fallen by the wayside, or they come home and they're supposed to start, but then they go back in the hospital 2 weeks later. They're in and out, in and out, in and out, and now, they blink and their kids haven't actually had the immunizations that they're supposed to have. Is there Any recommendations for immunization around critical illness or times that should be waited, or ways that our parents can keep this in mind so that our kids can work with their pediatricians and their care staff to catch up? And what is the most appropriate time to start catching up a child who's had critical illness and kind of multiple open heart or other types of surgeries?
Yeah, great question, because that type of a situation comes up a lot. So we generally try to avoid giving immunizations around particularly stressful times, like surgeries or critical illnesses. We would like kids to have recovered for about a month or so and be at their baseline before we start immunizations. And then we would try to get them caught up with a reasonable schedule. But you're right that critical illness is not a good time to do immunizations. And certainly around those times, it's good for them to be on their antibiotic prophylaxis and be monitored a bit more closely.
Check marks for competition. On the note of our young ones, in heterotaxy, it is a trend that first year, that first 2 years is when they spend the majority of time in and out of the hospital, or mostly in the hospital. Can you speak to about Synagis and RSV? And I mean, this was a decade ago for my daughter, but she got Synagis, the series, for her first 2 years, and we were told at the time the only reason why it's only the first 2 years and not any further is because that's as far as insurance will cover. But I'm wondering what the standards are right now and what your recommendations are for our kids on that.
Yeah. So I think that still applies, but I don't think there's a one-size-fits-all. So I think it is good for the kids who are in the hospital a lot, on the cardiac service, to get immunology involved with them while they're inpatient. And then, if you can have a team, the cardiologists, the pulmonologists, and the immunologists, if they feel like a child is at risk for respiratory decompensation, advocating for an additional dose the next year, I would firmly support that. But it's, like I say, it's not a one-size-fits-all, right? And some of these kids go through some really difficult times. So I think RSV is a drop in the bucket, in terms of getting the immunization or the immunoglobulin compared to what they've been through. Anybody else? Well, I hope this was helpful. And I'll be around tomorrow also giving a talk on immunologic evaluation a bit more in depth tomorrow afternoon. But it's been a pleasure to chat with you guys today.
All right, thank you, Dr. McDonald. We're going to have a break for a little bit until our next presentation, because that one will be virtually. So we'll be back in about 20 minutes.
actually had a genetic analysis. And it was all just intestinal manifestations, nothing like extremities. Okay. But when you're having similar types of issues within a family, could kind of think it was a red flag. Stories like this one is why what we're trying to do is standardize approach, right? We're trying to do one size fits all. So some more complicated patients may need significantly more support. Again, this is somebody who's kind of falling outside the guidelines, right? But I think as physicians, we need to be attentive to parents kind of understand. And there's that whole sort of mansplaining and all that. For these kids, you really do have to kind of stand your ground and say, we really need to investigate this. I saw that, yeah.
And then in the sound settings, we're just going to make sure that your output
I know, like, this isn't my computer.
No worries. So,
Oh,
just go ahead and click on that.
where the mouse was, there we go.
And headphones. We're good.
Great. Okay.
Unless he has that set up. That might be it. When he gets back, I'll see how he has it set up over
Okay.
there. It's going to be one of those two. So.
Okay. We're getting there. We're getting there. Well, here, I can start it.
Recording in progress.
Okay. Good.
I can bring him up here. Do you want to talk? Hi, Vincent. Can you hear me?
I sure can. Can you hear me?
Okay, I see that you're talking. Can you hear him on your end? We cannot hear on our end. Are you muted, perhaps?
I am not muted and it shows that I'm green.
Oh, yep. Now we hear you. Yep.
Okay.
Is your audio all the way up on your? Oh, stand by. There's a 78. You want it all the way 100? Okay. Okay, Vincent, can you speak again, please?
Yeah, absolutely. How's your day going?
Wonderful, thank you.
Yeah,
How
of
are you
course.
today?
Doing pretty good.
Good. So we're just going to have you talk a little bit, and we're just going to try to mess with our audio on this end. So if you can
Okay.
just maybe
Yeah, sounds good to me. Test, test, test. Test, test, test.
sounds good.
Test 2.
Great. All right, sounds good on our end. Thank you very much. And
course.
if you can, just keep your camera on while you're presenting. Guess that goes without saying, but.
Yep.
Yep, copy that. Let's go full screen here. %, copy.
Sounds like you guys got a whole team.
Yeah.
So can you help me pronounce, is it heterotaxy? Is that how you say that? Or I don't want to mess up the wording.
I believe it is heterotaxy, but we'll give a, pronounce heterotaxy. Heterotaxy.
Okay.
And emphasis on the heterotaxy. Yeah, perfect. Are you okay with that view, or do you want a different view?
Let me go back to it, hold on.
Are you sharing a screen right now, Vincent, or will you be sharing a screen?
I will not be.
You
No.
will not. Okay. I do see Beth. Yes. Hi, Beth. Can you hear me?
Yes.
Okay, wonderful. I do see you. Would you be able to share your screen? That way we can test it.
I wasn't planning on sharing my screen for anything either.
Oh, that's not you. Then. Okay. Oh yeah, that's a good point. So just want to make sure, don't chat on your end because we'll see it pop up on screen on our end, please. Wonderful.
Good.
So I'll stop video on my end. Okay. Okay, there we go.
Then we gotta go active view, deactivate.
You want to go?
Hide, settings, video settings. Right here.
It was, trust me, the first one was like, yeah, and then after 3 months. From now on, because every time I ask her a question, she gives me the wrong information. And it's like,
Try to hide non-cameras. Remember where it is on a PC.
every month there's a call number going,
Yeah, that's just about our camera.
you need a referral here.
But to hide the people that were hidden cameras, I don't want to see them. View. Okay. Keep cameras on.
I don't, I'm like,
Full screen automatically.
or not my phone, I'm like, never. I was until like I married and then. Then I don't think it'd be allowed to live with my husband.
Where's the hide number?
Yep, so with the request, yes.
Me and the more.
Yeah.
So really, it should default to whoever is talking.
Correct. I'm trying to do
No.
hide non-cameras.
I don't know how to do that.
It did do that for me when Beth was talking, it did come up with her picture on the screen, if that's what you guys are trying to do.
No, we did see that. I'm trying to hide people that don't have the camera on, to hide those participants.
Okay.
Sounds like a ChatGPT question.
Right?
And do we have to have the?
Click the arrow next to the stop video
Mm-hmm.
and button in the meeting controls. Select video settings,
Mm-hmm.
and then it says hide non-video participants option.
Yeah, that's what.
I can also use the focus mode.
Mm-hmm.
Do we see focus mode?
More video in effect.
Is there a search function on this? I forget.
Virtual studio? No,
That's
that's
all
not
about
it.
us. Yeah.
Huh. Let's come down here. Enabling your test. Let's go to Zoom itself. AI might be giving us a bunch of stuff. Never know.
On the Mac, that's how it is.
Sign into my web portal. So I might have to do it from a browser. So let's pull, just click here. And you can just type in Zoom.
You're okay
Yeah,
with
you're good with
closing
that.
this?
Yep, I'm done with that.
I think it's resume that.
Yeah, it pulls up right away. Okay, account management.
Yeah, you might have to choose that option when you create the meeting.
And I might have to kick them out. Okay. And then select account management, then account settings. My meetings tab. The schedule meeting.
Okay, so it is off. Start meetings with participant videos on.
Yeah, all you can do is
like
That
basically,
is for the overall meeting.
yeah,
not- Then the world is so like have it as pretty as possible.
Maybe participants on the right side? Nope. Hide non-video participants?
Yep, that's it.
That's what I was looking for.
Okay.
and that's fine. You know, I'm gonna just show you back.
Okay. Alrighty. Let's hide this cursor though too. That the mouse was just right in the middle, so. It's still there a little bit, but let's get that out of the way. Make sure that disappears. Golden.
All right. All right, welcome back, everyone. Our next presentation will be about nutrition and tube feeding, and it'll feature Dr. Beth Gore and Vincent, who's the Community Engagement Coordinator and Long-Term Patient. So Dr. Gore has a PhD and is the Chief Executive Officer of the Oli Foundation, a national nonprofit dedicated to supporting people who rely on home parenteral and enteral nutrition, a longtime patient safety advocate, author, and speaker. Dr. Gore brings deep expertise in vascular access and nutrition support to her leadership role. She champions the voice of the patient on national committees, boards, and task forces, striving to shape policy and practice to improve outcomes and quality of life. A mother to 6 adopted children with special needs, including a son who depends on a central line for lifelong nutrition support. Beth's advocacy is grounded in lived experience and unwavering commitment to her community. All right, Dr. Gore and Vincent.
Hi, everybody. Thanks for having us today, and thanks for the introduction. I think the very best way that I can possibly start off to give the center stage, I think that's important voices that we can possibly hear from as somebody who grew up on tube feedings and nutrition support and has lived to tell the tale. And so I'm going to turn it over, including his own introduction. Vince Roche, please take it away.
Hi, everybody. Thank you for having me today. Like Beth said, my name is Vincent Roche, and I've been a patient since I can remember. I was born pretty normal on October 3rd of 1991, but about 9 years old, I started having some major issues. And similar to heterotaxy, I had a malrotation in my intestines and had a LADS procedure to try to fix that. That did not fix all of my issues, but with the support of nutrition support and great caregiver, my mother and doctors, I still live on nutrition support today, but I live a pretty full life, and I am the community engagement coordinator for the Oli Foundation, and I advocate for the enriching the lives of patients and caregivers and really making sure that we bridge that gap so that way patients really have a source and resources to be able to get the information they need, so that way they are having the education so they really don't go without. Also, having a connection with someone like them is very important. That's something that I didn't really have until a very older age. I felt like I was alone in this world and I was the only one like me. And until I found someone that was like me or multiple people like me, it really made my life a lot better. Today, I am the community engagement coordinator, and I also have I have a house, I have a dog, I have a girlfriend. So it's been a really great experience, and there's been some major ups and downs for sure, but I will say there's been a lot more ups than downs because of the support that I have behind me and the advocating that I've done for myself. I would like to say that the patient voice is very important, and it matters more than I think any other voice does, as well as the caregiver, because we are the one that is facing these obstacles directly head on, and we are the ones that are going through these ups and downs, and we need support more than anyone needs support in this world. And I'm just thankful that I had great parents and great doctors and that I was able to get that support. And I'm really thankful that nutrition support has been able to let me live a great life, I would say. It hasn't been the best life, but I would say it's been a great life. And thankful for all the innovations and all the things that have come from the nutrition support community as well. Well, I couldn't be happier to be where I'm at now, and I'm glad that my lived experience has been able to bring me to such a great foundation and such a great life to be able to help people connect and really educate them on the life that is possible while on nutrition support. I've even done things like travel to Spain and travel to Rome, and all of that is possible because of the nutrition support that I'm on and all the support that I do have. So thank you guys for having me so much. It's been a great experience to be here, and I'll turn it over to Beth.
Well, thanks, Vince. I actually want to ask you one very specific question. And could you give us like one of the hardest challenges for like tube feeding specifically? And then what was like a suggestion besides plugging into community, which you emphasized really well, but like what's one of the bigger challenges you've experienced and what were some of the tips that might have helped that?
I think the biggest challenge was really having almost no education. Back in the day, when I first grew up, we had limited education, and it was kind of just thrown at me and my parents. And I think that that really was a big challenge for us. It was almost like we had to learn how to do this almost on our own rather than have education to be able to provide a guide or a path for us to lead us down. I wish I had a yellow brick road that I could lead myself down, but unfortunately there was no brick road. It was just, this is going to be your new life. And I also wish, I think one of the other biggest challenges is figuring out how to live life like this. What was going to be my new normal from so many other people. And I think the biggest tip that I can give is ask as many questions as you can. Really emphasize, what is my life going to look like on tube feedings? Can I still do this? Can I still do that? And advocate for the life that you really want and partner with your care team or the team that is managing your care. I think if I was able to partner with my care team a lot sooner, I would have been able to do a lot more in my life that I'd missed out on or thought that I couldn't do. But in reality, after partnering with my care team, or the team that manages my care, I was able to do a lot of things that I never thought was possible by asking those questions and really making sure that I was able to live a full life, because I like to say, what is life? Why live life without living a full life, right? So I think that asking those questions and then also having a plan A, B, and C, because sometimes, doctors suggest one thing, but that may not work for you or the next person. So I think having a backup plan or an option that if this does not work, I think would have also been very helpful. So asking a lot of questions and really making sure that you're aware of what is going to be happening next and after that if it does not work.
First of all, thank you so much for sharing your insight. And I think those resound very well with me too as a caregiver. So as my introduction, I have 6 children. One is on 2 feeds. He's now 16 and he has been since birth. But I don't have a feeding tube. And so I don't know what it's like. I call that side adjacent or front row cheerleader to what it's like. I could tell you about the navigating the road and talking with, advocating on his behalf and in the insurance and things like that. But I don't know what it's like to truly live it. And so Vince, thank you so much for sharing a little snippet of your life, because I think that gives encouragement to that you can live. It's I think that's one of the things about tube feeding that I want to get started with is it's said in hushed tones like it's the end of the world or it's an end of the life decision or it's the last thing. Now I'm going to say on the other side is if people don't give them a tube. It's that simple. We're not advocating that everybody should be born with one or given one, but if you need it, you need it, and it's okay. And there's a stigma, a really negative stigma sometimes associated with tube feeds, which I think is quite unfair. And so, as a mom of somebody on tube feeds, and then also as the CEO of the Oli Foundation, I can tell you one of the things that we fight for is that we fight for patient safety. So we want to make sure that all patients that have tube feeds either before they're on there, as they make that decision to say, should I not? How do I work with my team to know if I'm ready for one, if I need one, while you're on it, and then the whole time you're on it until you either no longer need it or the end of your life, is how to be safe while you do that. And have part of that is the education, like Vince just talked about. The second thing that we really fight for is to be able to, for all patients to have access. And what I mean by that is access to every option. What are your options? So just because you were given tube A doesn't necessarily mean that's the only tube for you, or formula A, or feeding schedule A. Those may or may not be the perfect solution for you. And there are options. And so many patients don't know that there are options of tubes or pumps or the rate or the speed or the formula and things like that. And so it becomes a thing of you get what you get and you don't pitch a fit. I think that it's important to know that there are options. So if something isn't working, it's okay to work with your team and say, hey, is there a better way? Do I have more options? The other part of access is to access to knowledge. I think Vince just highlighted that pretty well, is are there choices, but also who knows, and what questions should I be asking my provider? I think for me as a caregiver, so many times I felt like I was the only one. Vince just said the same thing. I felt like I was the only one. Maybe I'm a bad advocate. Maybe I don't know how to advocate for my kid because he's struggling. Maybe I'm just in a bad hospital. Maybe it's that. Maybe I have a bad insurance and that's why I'm getting mistreated. Maybe it's, and you fill in the blank with all of these, maybe it's something that I did. But it may not be any of that at all. And so realizing that when I have knowledge that connect with other people, they start to say, I'm having that same trouble too. And I'm like, oh, maybe it's not me. Maybe I'm not the only one. And so that gave me encouragement to be empowered to speak up kindly, always kindly, but to speak up for what's going on, what's going well, what's not going well. What are my goals? What's working, what's not working? And really to partner with our team. And the last piece of access is about community. I think Vince also mentioned that too, is really plugging in that you don't have to be the only one. I'm so glad that you guys have found this organization, your organization, and you probably understand the value of community, to not be the only one. There's somebody else like me, there's another caregiver like me, and so forth. But the power of not doing this journey alone is so much more valuable than I could ever articulate. I think it's just so important to know it's not my fault. I didn't do this. I don't have to do this alone. And I think as a caregiver early on, with my really, really complex medical kids, especially my last one, Manny, who's 16, I truly felt like I had failed him so many times. And I wish somebody would have come along early on that just says, Beth, you're doing your best. And encouraged me and stayed with me. So I don't know if I'm speaking to other caregivers here, or maybe that's just my experience, but I don't think so. Is I feel like if I had only spoken up sooner, if I had only fought harder for that, if I had only, and you fill in the blank, and we really get quite heavy on ourselves. And somebody told me along the way, you did the best you could with the information you had. And that sort of started to help me realize maybe I didn't screw this up. Maybe I would make a different choice now, but that was the best I could with the information I had. And so I just want to empower you. It's okay to speak up. It's okay to know that you have options. It's okay to want to communicate with get more knowledge, and it's okay to want to connect with your community. One of the phrases that Oli has used over the years is help along the way, because to me, that's the most important thing that we can do is how do you live with? So I've talked about Oli comes along for, do you need to get on tube feeds or not, the safety aspects, the 3 types of access, but really where we spend a majority of our time is living with. So this isn't a death sentence. It's not the end of the world. You can actually go live. Vince just talked about being to Spain. I haven't been to Spain and I don't have a tube feed. And so you truly can live. And so that's actually Oli's mission, is helping people in nutrition support thrive. And we do it through the different mechanisms, but that's the most important piece that I think I could emphasize today, is that if you are considering getting a feeding tube and you need it, if you already have one, there's ways to live. So we go about telling people you can travel sometimes with, that shouldn't be the limiter. Other things may limit you, but tube feeding shouldn't be your limit to if you can travel, if you can go on cruises, if you can go international, if you can do certain sports potentially carefully, if you can, maybe have a relationship one day, maybe you can get married one day. Some people can have babies, some people can, like whatever you want for your goal. And so that's one of the most important things that I think I could leave is working with your care team is what are your goals? What are your child's or whoever's the patient? What are their goals? If it's just less days of distress, maybe it's reducing when they're in pain. Maybe it's putting on a couple pounds. Maybe it's whatever those goals are. Maybe it's go to Spain. Whatever those goals are, to be really intentional. And how do I work with my team in order to get that done? Now, my child does not have this syndrome. My child has an ultra rare form of muscular dystrophy, and his other conditions are way more life limiting for him. His use of wheelchair, his inability to do things against gravity, and so forth. There's a lot of life limiting things because of the diagnosis that he has, secondary to why he needs nutrition support. But nutrition support shouldn't be the reason that people don't stop. It's just a way to eat. And so that's the message that I would like to do today is encourage everybody that if you have questions, if you want to community, if you want to know options, if you want to have access to these other things, feel free to plug into your own organization, plug into the Oli Foundation, and be encouraged. Just like Vince has said, you can go live. And we would love to offer any of that help along the way with the Oli Foundation. So thank you so much for your time today. I don't know if we turn this back over, or if there's questions or however that works. So I'll turn this over to whoever's in charge. But thank you for your time today.
All right, thanks, Beth and Vince. Are there any questions from the crowd? All right, well, thank you very much for your time and for what you had to share with us today. We're going to have our tea time right now, where you can go and kind of mingle and get to know each other. Just a second here. Okay, so you can go out to the lobby and you can sign up for Citizen Health with Maria. Renee will be out there to talk about Courageous Parents Network. Monica will lead you towards sharing your story for future advocacy. And if you want to, you can take pictures in the back. Great place to go. And then also for tonight, for those that want to go to dinner somewhere, like you guys can work it out. I've seen several people put it in the group me, but just whatever you guys decide, please put it in there so that no one feels left out if someone decides to go. All right, we'll break. Thank you.